trying to make sure I can get my slide to progress. Oh, it's not progressing.
It's okay. You need to actually share screen again because we've turned it off.
Got it. That's what it is.
Yes.
Okay. Hold on, everybody. Let me just do that.
Sure. And welcome to all those who have joined us.
Can you guys see it now?
Yes, we do.
Perfect.
Thank you.
All right, here we go. Oh, just trying to get it progressed. There we go. Let me make sure it's working. Okay. So really quickly about me, just to kind of go off what's already said. So I do specialize in treating trauma, particularly complex and developmental trauma, which we see a lot of childhood neglect. I specialize in EMDR, somatic experiencing, attachment, and parts work. So we'll be talking about some bottom-up approaches today. And also what might make this training a little bit different from some ones that you've been in the past is I'm actually a child neglect survivor. So there might be certain points in the presentation where I give you, clinical information, but then also a bit of personal stuff from my experience. So that might be at times where this presentation is going to differ a little bit, but I hope that adds a bit of a different perspective. So what is child neglect? I think it helps just to kind of start with a few definitions. First of all, I think it's very helpful to know that the legal definition and the clinical definition of child neglect are not the same. The legal definition actually varies in states, and you can see it here. Failure of a person who's responsible for a child to provide needed food, clothing, shelter, medical care, or supervision. So you see how it's very sort of detailed. And when we're considering these definitions, here's what I tell everybody. When you're defining childhood neglect, as a clinician, it's probably best to focus on your clinical assessment and report child abuse or suspected child abuse to the authorities. So as clinicians, we don't want to investigate allegations. We want to know about abuse, absolutely, but not investigate. I say that because it's actually very easy to re-traumatize children or adults if we go at it such as a legal investigation. If you're not working with a legal agency or you're not trained in that, just know that investigation, it's okay not to do that. In fact, you probably shouldn't. You should just report and allow the authorities to do that. And remember, when in doubt, report. If suspected, go ahead and report. So the clinical definition of child neglect is the denial of attention, care, or affection considered essential for the normal development of a child's physical, emotional, and intellectual qualities. So that is much more general than the definition of child neglect from a legal perspective. So that's important to note. So some people might say child neglect and mean something very different than what we mean on a clinical side. So here are some types of childhood neglect. Physical neglect tends to be the one that we hear about more often. This is when a pattern of basic needs, food, water, shelter, clothing, are not provided. This can be very, very obvious. Sometimes it's actually not. So a child that is locked out of the house when they misbehave, that's child neglect. Sometimes it may not appear that way, but it is. The child is being denied a basic need of shelter. And also when a child needs to meet their own basic needs, that's also neglect. Now here where it becomes a little bit iffy is what if a child is actually meeting their basic needs? What if they are, cooking mac and cheese at 5 years old and they're doing a great job and they're feeding their siblings? That could also be child neglect. So sometimes it's not apparent. We'll get into that in a minute. So physical neglect is a type of child neglect. Medical neglect. So the medical treatment for a current or pre-existing condition is just not provided. And this could be times when a child breaks their arm and they don't receive medical care, or they have a condition and they don't receive an evaluation or follow-up treatment. Now, this can be physical or mental health. So that's important to note as well. Sometimes we will come across adults who it's been kind of obvious that they probably had some mental health issues as a child and they never receive treatment for that. So that can also be a type of child neglect. Supervisory neglect. The failure to supervise a child from being harmed or have someone else supervise a child to prevent harm. And so some of your, more obvious could be a parent just not being at home or not organizing some supervisory care for the child. It could also be younger or incapable older children who are left alone. A child who is 13 might sound like an age where they can, be okay a period of time alone. But if that child is incapable or perhaps struggling with something, then that wouldn't be a good alternative. And also children who are supervised by harmful or incapable older siblings or adults. So I do want you to think of that word incapable, because I think sometimes when we think of neglect or abuse, we think of perpetrator, right? Or harmful. But also there are people who are simply incapable as well. Environmental neglect. So this is when the actual home environment or the place where the child is living is unsafe or potentially harmful. These can be the unclean homes, the homes that, with parents or caregivers that struggle with hoarding, infestations of animals or insects, or a risk of injury or illness to the child. Access to drugs or weapons in the home is also considered unsafe. Also is exposure to domestic violence. That is a big one. We see that a lot in child neglect. It could be, physical domestic violence. It could also be emotional abuse of a parent, could also create sort of an unsafe environment and emotional environment. Educational neglect. So denied access to education. The child just doesn't have access. They may not be enrolled in school or have homeschooling opportunities that are provided to them. They may also be enrolled in school or not required to attend. I've encountered this where some children do not want to go to school and they are not required to do that. It's just too stressful and, mom and dad just don't want to have the fight. But that is actually considered childhood neglect and a big sign that the family needs some services and support. Now, here's the big one. This is one that it is so rare that I don't see it. If someone has experienced childhood neglect, child or adult, is the emotional neglect. This is huge. So if there's any type of childhood neglect, I want you to have your eyes on, it's this one. This one could be the most pervasive. This one could be the one that's mostly unnoticed. It's the emotional neglect. Now listen to this. There is so much wrapped up in this definition of emotional neglect. A child is deprived of emotional needs. So these are opportunities to develop secure attachments to caregivers, the ability to learn emotional regulation. Emotional and physical abandonment comes with that, and opportunities to develop self-worth. So with emotional neglect, there can be flat out obvious emotional abuse, name calling. Okay, we can decipher that. If a child or an adult tells us that's happening, that's pretty evident. Shaming, one that may not be. A child that receives the message that something's wrong with them, or perhaps blaming, things are their fault when it's not actually their fault. This could happen in a way that's very obvious. It could also happen undercover and be very hard to distinguish. A child who is participating in unhealthy family roles. Parentification, if you haven't heard this word before, this is when a child parents the parent. The child moves into a parent role for many reasons, but this has long-lasting negative impacts on the child. The child has to act as a caregiver, not just for parents, but maybe for siblings or other family members. The child is participating in triangulation, such as if a child is teamed up with one parent and then we have another parent in a triangle, or perhaps the child is teamed up with a parent against siblings. It creates a power dynamic. It really disrupts all forms of attachment in the family. When a child is labeled as the black sheep, when children are labeled as black sheep, they act like black sheep. They really struggle with shame and self-worth in regards to that. Now, here's one you may not hear not a lot about. When a child has the label or the experience of the golden child. This was me. I've made straight A's since I was in second grade. I took care of my mother. I took care of my younger brother. I was the golden child. I can do no wrong. And that was severely damaging. Sure, I got 2 degrees. You know, I emotionally regulate pretty well. But in regards to attachment and self-worth, highly damaging. So we don't want to lose track of these golden children or these perfect children that might be slipping through the cracks and actually experiencing or have experienced child neglect. And also a lack of attention, attunement, and attachment, and a lack of that emotional support or co-regulation. So for those of you who know a little bit about Dr. Tronick and his still face experiment, this is the best way I can describe how that co-regulation takes place. Imagine an infant or a toddler looking at a parent, and the parent's looking at them. And what we do naturally is we mimic and we mirror facial expressions, hand gestures, we're talking, we're doing all of these things. Now imagine that you just go to a flat face. That wasn't even a minute, and I wonder how many of you felt uncomfortable. I was not responsive. So if that happens with a child, what they tend to do is they try desperately to get your attention. They'll do everything they can. Eventually, they lose control of their emotions. Sometimes they lose control of their body, and they don't know how to regulate. Children regulate based on us, the adults in their lives. How does a child know that they exist? Well, first off, they don't. They only know they exist with us, with our interactions with them. Children are not born with just a sense of self-worth. They learn that, and they learn that from the very, very beginning. So when that is disrupted with childhood neglect, that can be extremely detrimental. So caregivers, attachment figures show children that they exist, that they're valuable, that they're worthy, and not just tell them, they show them. Eye contact, touch, all of those things that may happen naturally if children don't get that in that type of neglect for one reason or another. It's very, very difficult. And it's very difficult to learn to manage your own emotions. If there's a child in front of me right now and they're crying, I might assess the situation, make sure they're safe. I might immediately provide touch. I might ask them to look at me. I may hold them. I may make some soothing sounds. I'm calm, they're not, but eventually they're going to be as calm as I am. That's that co-regulation. And that is very important and a pivotal piece of this. So it's not just does a child have food, clothing, water, shelter. It's what is the child lacking? With childhood neglect, the biggest way I can distinguish this from physical abuse and sexual abuse, with childhood neglect, a lot of times it's not necessarily what happened, it's what didn't happen. There are a lot of obstacles in assessing childhood neglect. I've talked about a few instances where childhood neglect can appear less obvious or overlooked. Here are the main obstacles that I've experienced in assessing childhood neglect. A lot of our clients, children or adults, are terrified that we or other people are going to see their parents or their attachment figures as bad or abusive, even if they were, okay? Even if we feel like they are, the child or the adult doesn't want to believe that. It's really, really difficult. So a lot of times they will avoid disclosing childhood neglect because of that. And a lot of times what I've noticed helps if we rephrase that. You know, your caregivers weren't bad, they weren't abusive. And that's especially if the child or adult don't believe that. So we're going by their lead. We're not putting words in their mouth. Perhaps they were more maybe mentally ill. Perhaps they were traumatized with intergenerational trauma, or maybe they were simply incapable. Again, that word incapable is coming back. I want to bring that to the forefront because that has made a huge difference with some of my clients that are reaching for an explanation. Sometimes they get one, sometimes they don't. And sometimes what clients come to is, oh, they were incapable. They weren't able to do these things. My mother and father were incapable of attachment. It took me a while to get there and realize that. But I got to tell you, that makes so much more sense to me than, well, they were just bad. They were just bad people. My parents were actually kind of decent people. They were nice. They were just incapable of taking care of their children. So you see the difference there. So that can be an obstacle, that labeling of caregivers. Shame is a big one. If a child or adult believes there's something wrong with them, then it's very difficult for them to recognize or disclose childhood neglect. That's like me telling you I was a bad kid. I wasn't any good. That's really tough to say, to admit, and to experience. Now remember the difference between shame and guilt. Guilt, I'm pointing out away from me. Guilt is the behavior. Shame is who we are. And a sense of normalcy. Sometimes our clients don't know they're experiencing childhood neglect. I got a bachelor's degree in psychology, a master's degree in counseling and guidance. I didn't know I experienced neglect until after a year of practicing. Explain that to me. I had all the knowledge, but I didn't know because my experience was normal and I was very isolated. I didn't have access to a lot of other children that had different experiences, and my cousins had very similar experiences because of the trauma in the family. So how was I supposed to know? I simply didn't. So sometimes we work with clients and 6 months later we find out, oh, you experienced neglect. That happens because sometimes the clients just don't know. And also we've got some cultural societal issues. So sometimes we believe that children are small adults, which is not true. They do not have the cognitive ability of adults, and they will not until the age of 25 or 26, depending upon brain development. So a 5-year-old child cooking mac and cheese isn't age appropriate, not small adults, but that can be an obstacle in identifying this. The feeling of that's how it was back then, I've been there myself. I have said to children, you don't know what an encyclopedia is. I didn't have an iPhone. I didn't have the internet, all of those things. We tend to do that sometimes. And sometimes we can look back and say, oh, you know, it wasn't that bad. That's how it was back then. When in actuality, it might have been child neglect. Latchkey kids. This comes more from the 80s, early 90s. Kids who, you know, had their own keys to their households. That does not necessarily mean they experienced childhood neglect. But some of these children who are now adults or children now do. So there needs to be more of a thorough assessment rather than, oh yeah, I'm just a latchkey kid. Some economic issues make it difficult to identify childhood neglect. So poverty, single parent households, particularly now with this pandemic, can influence childhood neglect. It can, but it isn't childhood neglect. It doesn't equal childhood neglect. There are many families who are in poverty, who are struggling financially, that do not neglect their children. Also, I've seen it on the other end. I've worked with very wealthy families and children who see mom and dad maybe one day a week, if that, and they attach to the nanny. It's wonderful they have this attachment, but it could actually be that emotional neglect piece that we talked about. And sometimes in this culture, it could be, well, you know, we're wealthy. This is how our culture is. The children are raised by the nanny. I get that. But there could be neglect experiences in there. So you kind of see how some of these things can make it difficult to assess if our clients, or even if we have experienced childhood neglect. Intergenerational trauma is trauma that's been passed down in the generations, either by genes or socialization, often both. Trauma that comes up, we see it in the way we parent or interact with others. And sometimes religious beliefs can be an obstacle in identifying that. You know, certain religious beliefs may cause us to relate to our children differently. For example, the LGBTQA community. There are certain Christian religious beliefs that say, you know, we do not support homosexuality. And because of that, it could influence some childhood neglect, but it's not childhood neglect. Okay, it doesn't equal it, but it can make it difficult to assess. So I'm going to go through just briefly the assessment pieces. So when we assess childhood neglect, it's very important to know, what is your intent? Are you intending to assess for diagnosis or treatment? Not necessarily the same thing. I have worked with clients who've experienced extreme trauma, and they don't meet a criteria for PTSD. I've worked with clients who've experienced childhood neglect and are receiving treatment, but they have a diagnosis of ADHD or generalized anxiety. Our diagnoses don't always match up with our treatment. Sometimes they do. Sometimes there's not that A to B direct line. So that's important to note. As I'm assessing, am I assessing for a diagnosis? Am I assessing for treatment? That might help to sort of differentiate them just a little bit. And assessing for the experience of the client and the impact. There are people who've experienced severe childhood neglect, severe trauma, and they don't need treatment. Why? Because they're not impacted by that. So that's very important to note. So just so we're clear, and I want to say this because the word trauma has been misused a lot in the profession. Rape is not trauma. War is not trauma. Child neglect is not trauma. Trauma is a reaction to experiences. It isn't it. It doesn't equate it. That's important to know because we may come across people who have experience that actually don't meet the definition of trauma. They don't have those resources, or they've developed that resiliency, or they've worked through that. So that's important to know. Also, when it comes to assessing childhood neglect, take your time. This probably isn't something that's going to be neglect in the first session. This might take multiple sessions. And like I said, this can come out 6 months later. So don't feel like you need to rush with this assessment. One of the best ways I assess childhood neglect is in the actual interview, again, over a period of sessions. This works best with teenagers and adults or their caregivers. And it could be very direct questions, like, have you experienced childhood neglect? Clients who have been in treatment before, this is kind of the types of questions that I'll bring with them. If they don't have a lot of experience in treatment, or I get a sense of that, I might go more specific, like, did adults always provide you with food, clothing, shelter, or medical care? What was your childhood like? What was it like at home? Was there anything about your childhood that wasn't so great? Is there anyone in your family that you trust? These are questions that could lead to some great dialogue, some great details. We're going back to my example of my normalcy. If you would ask me, well, what was it like at home? I'd be like, oh yeah, it was fine. Nobody was there, but it was fine. As a clinician, you'd be like, well, that's interesting. Mom and dad weren't there. Let's discuss that. So you get more and more information. And with children, I look more towards their observations, their play, and I might even set up some scenarios, some house scenarios to see what they do. Also drawings, and the child's relationship dynamics with me gives a lot of information about experiences of neglect. So here are drawings from a 14-year-old boy. This boy did not speak to me for 6 sessions. He just didn't. He didn't want to come to therapy, and I was cool with that. So we just hung out. But I asked him to start drawing, and I drew too. And this is what he drew. So this is a boy that actually experienced neglect in his biological mother's household. He was in foster care. And the neglect that he's describing on the right is from biological mom, the anger that he has to keep hidden in. This is a golden child. This is the one that does everything right, the older sibling. Now on the left, this is neglect from a caseworker. And this was hard to hear. So the caseworker would leave him and his brother alone with their mother when she wasn't supposed to. So he would draw about that. So this is a kid that kind of had a double whammy with adults. But this is how I assessed it, not exactly through his words. Okay, so there's a few additional ones. So we have the clinical interview. But if you prefer kind of more of a structured assessment, there's a few that I like. The Adverse Childhood Experiences, or ACE, is wonderful. It is 10 questions, but don't be misleading. The 10 questions have like multiple questions underneath them. And so basically what this measures is the most commonly related experience to physical abuse, sexual abuse, and neglect. And I like this because there's a neglect component and a family dysfunction component, which we don't see in a lot of assessments. The link is below, and this is available online for free. We love free assessments in this field. The ENQ, or the Emotional Neglect Questionnaire, this is 19 questions. This is for adults or the caretakers of children. And this, I like it because it's very general and it can prompt a lot of discussions, but it's pretty simple. And this is something that you can give to a client, have them go home, have their caretakers do it, or you can do it in a discussion. And these are some questions that you wouldn't think to ask. Now, know that you can use this assessment as is, or you can borrow some questions for it for your clinical interview, whatever you feel is best. So some of the questions that I really love is, do you find it easier to love animals than people? I love that. That is an attachment question. You're going for that attachment root in that emotional neglect. You know, do you judge yourself more harshly than you judge others? There's the shame piece coming at. So this is a great one to look into as well. And if you would like some other structured assessments, here are a few resources that have done a really good job compiling them. There's a ton of them, so try not to get overwhelmed. Now we get to treatment. Thank goodness she's finally talking about treatment. So before we get in, just a reminder, the impacts of childhood neglect, and the impacts meaning the issues that are going to need to be addressed in treatment are the attachment issues. Definitely, you can't get away from that. The mood disturbances or the struggle to manage their moods as a child or as an adult. And I see this a lot that is more distinct in childhood neglect. Anxiety related to physical or emotional safety and meeting basic needs and finances. So I work with quite a few adults now who've experienced childhood neglect. These adults could be CEOs making all this money, but they honestly feel like at any time they're going to be on the streets without a home. Adults who feel like they don't know where their next meal is coming from, still to this day. So I've seen this anxiety linger and stick around. Low self-worth and pervasive shame, that is a huge one that also needs to be addressed. And somatic symptoms, those physical responses. When I work with a survivor of childhood neglect, I want to know, do they have pains? Do they have muscle tension? How is their body responding? What is their relationship with their body? If they have any relationship, do they feel safe in their body? Many of these people don't. So with treatment, if you hear nothing from this presentation, if you just tune me out, everything I say, this is the moment where you shouldn't tune me out. Because without a safe relationship with this population, you have nothing. Nothing. You can have the best therapeutic ideology and intervention known to man. It can show to be 99.9% effective. But if you haven't developed and maintained a safe relationship with your client, you have nothing. It won't work. So please hear that. So with this population, children or adults who've experienced childhood neglect, we need to make sure that our relationship with these clients is a priority and always is a priority in every phase of treatment. We have the ability to model secure attachment. Think of it this way. If your client has never experienced secure attachment, you can be the first. You're going to be modeling that attunement, that acceptance, having boundaries with your client, safe boundaries, showing them how to do that, and also modeling conflict and repair in a healthy attachment relationship. Things aren't going to go great all the time, and that's wonderful. They're not supposed to, but we can model what it's like to have a break in the relationship and to repair and even have more safety. Going at the client's pace is a big one, especially for children. It's, not forcing a client to participate in an intervention or do anything. We do not force clients to engage in treatment, even clients who are required or mandated. The child, the boy that I told you about, he was mandated to come to treatment because he was in foster care and all of these things happened. He had to come. He couldn't say no, but he didn't have to participate. I didn't force him to participate. We threw balls around, knocking things down in my office. The therapist next door was not very happy with me. But over a period of time, he started to talk, he started to open up, and he started to make progress. So sometimes it takes quite a bit of patience. Safety tests. This population could have safety tests of their clinicians and other people or anybody that they're in a relationship with. So I tell clinicians, anticipate safety tests and pass them. A safety test can be something such as, I'm going to come 5 minutes late to session and I'm going to see if you give me a hard time. You know, and sometimes these tests are the client's very aware they're doing it. A lot of times they're not. And sometimes I've had clients come back after months and say, you know, I think I was testing you, but I didn't realize that I was doing it. And I'm so glad that I passed those tests. So know that those tests may be coming and they might mimic what the adult or child has been through with other adults. If I learned that if I stop talking to you and you go away, I might do that with you just to see if you'll go away. Or maybe I'll yell at you and see if you get mad at me. So know that those tests may be coming. Expressing vulnerability, and I mean our own vulnerability, when it benefits the client. Some clinicians really struggle with self-disclosure. That's okay. My sort of advice is if it benefits the client and you feel comfortable with it, give it a shot. And it could be something very small. It doesn't have to be these huge details about herself. I'm going to be honest with you guys. I don't tell my clients I'm a survivor of childhood neglect. They can find that information online. I've read about it, but they don't really bring it up because this is about them, not me. But there will be moments where I will share some things in the best interest of the client. When the election was going on, clients asked me, how are you doing? I was like, I'm stressed out. Oh my gosh, this environment nowadays. And clients were like, really? That's how you feel? Sometimes our clients need to hear those things. And considering the client's strength, interest, or learning styles. So if a client has certain hobbies, certain things that they love, actually bringing those in to therapy. Their interests. If a client's visual, I'm going to want to bring visual things. I might speak in visual words. If they're auditory, if they're kinesthetic, I just want to take notes of that and be aware with that. And with telehealth, we have a great opportunity with that. I had a client who is kind of very closed off, a survivor of neglect. I had him bring his guitar into session and show me some chords, sing me some songs, and that was wonderful for our relationship. Sometimes I feel like we're very good about doing things like this, creative things with children, but we miss the mark with adults. So remember, when it comes to childhood neglect, a lot of times we are treating those inner children, those smaller parts of the adult, and they're going to need some attachment and some relationship building. So with interventions, we're going to talk about just two types, top down and bottom up. So look at this. This is the brain. And I want you to imagine that these are stair steps. This is your first step, your survival state. Second step, emotional state. Third step, your executive state. So if I'm walking up the stairs of my brain, 1, 2, 3, and this is how our brain develops. 1, 2, 3. So what parts of the brain are developed or impacted with childhood neglect? 1 and 2. Okay, 3 hasn't developed yet. 3 is impacted, but 1 and 2 at the most. So this is important to know. So here are the two types of therapeutic interventions. Top down, we address 3, maybe a bit of 1 to really impact down, or bottom up. I'm addressing this, maybe a bit of this so that I impact the top. So I think it helps to think of your brain as an actual 3-step staircase. Top down treatment for childhood neglect. These are the interventions that we hear about most often, and they've been around for quite some time. Sort of your traditional psychotherapy, your CBT, your ACT. I just made a list. Now know that this is not a complete list of the top-down approaches, but the top-down approaches basically were accessing that prefrontal cortex, that executive functioning, to impact the second step, the limbic system, and then the survival state. So top down. If you're using these methods, wonderful. That's great. And you're seeing some progress. Here's one thing I'm going to ask you to do. Make sure you're using the trauma-informed variation. A lot of these methods have been updated, or they have a lot of great resources about how to make them just a bit more trauma-informed if they aren't already. So that's just a caveat that I would share with you. Now, let's go back. So that's top down. So bottom up. Now, bottom up are a little bit of the new kids on the block. They've been around, but not as much as the top down. So with bottom up, we're focusing on here, the survival state, and also at times this emotional state. So we impact the executive functioning. So with those bottom up approaches, look at this scan. This is, I believe, a 3-year-old. And so if you look at this brain, this is a child that has not experienced abuse. This is that prefrontal cortex. So look at this. Look how this is filled in. This is the activity here. This is a neglected child. These are dark. So the reason why those kind of bottom-up approaches exist is because sometimes we can't rely on that executive functioning or that prefrontal cortex. For one, in children, it's not developed yet, but also even if we have an adult sitting in front of us, these areas here might still be dark. So if I'm trying to help a client with maybe some CBT and I don't notice some progress, it may not be the CBT, it might just be the client can't access this part of their brain. So in order to help with that, we may try some bottom-up approaches. So some bottom-up approaches are EMDR, or eye movement desensitization and reprocessing. This is when therapy uses bilateral stimulation to access and heal sort of those lower stair steps in the brain. So bilateral stimulation, meaning accessing the right and left hemispheres of the brain in order to desensitize past experiences or implement or solidify positive experiences. And that bilateral stimulation can look like moving the eyes right to left. It can look like tapping on your body. There's many ways to do it. It does look very, very different from that traditional talk therapy. Somatic experiencing is a method where you focus on your body as a way to heal the trauma. So that might be, instead of asking a client, what are you thinking? I might ask, where's that in your body? What's happening to that feeling in your body? And actually staying in your body. Some clients that I've worked with, the neglect has been so severe that they cannot think about it. They don't remember it, or they don't have access to the prefrontal cortex. So we spend the entire session in the body. Internal family systems. This promotes healing by accessing and healing the inner parts of you. So this is where some of that inner child work is done, nurturing parts, protective parts, basically saying we have different parts inside of us, and some of those parts have some unmet needs that we need to get met and healed. And expressive art therapy is when you use many different art forms to integrate in order to heal trauma. So those are some bottom-down approaches. We can't give a lot of detail because those are entirely big presentations in themselves. So here's what I'm going to leave you with, some helpful tips. When you are providing care or treatment for a child or an adult who's experienced childhood neglect, here's some things to keep in mind. If you're working with a child, the current caretakers of that child should participate in therapy. Children don't live in a vacuum. So sometimes people think that they can kind of drop a child off from therapy and just have the child do the work, but the caretakers really need to be integrated that into, family therapy. It doesn't need to be a session all the week, but there does need to be some participation. When I work with children, I like to tease the caregivers and saying, hey, your child's starting therapy, and that means you're starting therapy. So I kind of like to kind of tease them and kind of bring them in right away on that and get their buy-in. If you're working with adults who've experienced childhood neglect, consider involving that adult support system. I don't feel like we do this enough in therapy. I've worked with adults where I've had one session with them and a partner, just one session. And the purpose of that session was helping the adult to communicate their experiences of childhood neglect, how that impacts them and how it impacts the relationship. Something as simple as that can make a huge difference in treatment. Also, when it comes to adults, consider some community support groups. Here are some good ones. There's ASCA, AA and NA could be a good support. Adult children of alcoholics and dysfunctional families could also be one. So sometimes our clients need a peer group. They need to be around people who have had similar experiences. childhood neglect is very isolative. And so providing them with these resources can make a big difference. Coordinating with school counselors, physicians, and psychiatrists for both children and adults. Sometimes I think we don't do this enough with our adult clients. Not overlooking boys and men. So this is in every aspect of therapy, but when it comes to childhood neglect, I have noticed a pattern of us being able to assess and treat childhood neglect in women or girls a bit quicker than we do men or boys. I'm tending to see boys come to me late or men come to me later in life because they didn't know and nobody picked up on it. This is probably going to be one of the most controversial things I'm going to say. When we do this type of work with childhood neglect, it's so important that we meet clients where we're at. And sometimes I have heard clinicians say that forgiveness of your caretakers, your perpetrators, or those who are incapable is required for you to progress in treatment. It is not. What is required is maybe acceptance, desensitization, moving forward. Now I get this is probably going to be semantics, the difference between forgiveness and acceptance, but forgiveness is a very charged word. And we want to make sure we're not doubling down on that shame or reinforcing it. If a client would like to work towards forgiveness, wonderful, let's go there. If a client's like, no, I want to move on, but I'm never going to forgive them, great, we can work with that. I have seen clients get to the point of acceptance more often than forgiveness. Acceptance could be this, this happened to me. This is part of who I am. I don't really, feel blame towards them. I'm not angry at them anymore, but I'm not going to say that I like them or I wish them well. And I'm not going to say that they're not accountable for what happened because they are accountable. I was a child. That's a bit more acceptance sometimes than forgiveness. And so just be careful how we use the word forgiveness in our treatment. Make sure we're following the client's lead. Make sure we're providing options and not requiring a client to forgive. And know that sometimes the word forgiveness has some religious connotations to it as well. So we want to be very aware of that. And this is huge. This is where I've messed up in my work, is not being completely aware of when my clients are disassociating. When we provide treatment for childhood neglect, a lot of our clients have learned to disassociate. Disassociating meaning things such as shutting out, or shutting down, or not feeling like they're completely present, or compartmentalizing. The flooding, the panic attacks, the hypervigilant, we tend to see that. I can see it on telehealth all the time. But when a client is shutting down, when they're not completely present, that can be harder to distinguish. Now, here's the hard fact. If we're providing our client with treatment and they're disassociating, they're not going to make progress. They have to be present. At least 1 foot in the present, 1 foot in the past, dual awareness. If they have both feet in the past, it's going to be very different to make progress. So noting, are our clients disassociating? What does that look like for that particular client? And noting that it could make a huge difference in my treatment if I take 2 minutes and help the client come back to the present moment, or I stop because it's becoming too overwhelming, things like that. Trauma work isn't something that it's A to B and we're done. And that includes EMDR. There's this misconception that 5 sessions of EMDR and you're great. No. That single event trauma, that is not complex trauma, that's not developmental trauma, that's not childhood neglect. EMDR is also a process, as are those bottom-up techniques. It is not A to B trauma work. Sometimes it's A to Q to C. We just kind of go all around there. And hopefully eventually we're getting to B. So really keeping eyes on that disassociation. And so from a personal aspect, I'm going to share with you what worked for me. This is the survival coming out. So I did talk therapy, which actually helped me with my attachment and developing relationships with therapists. I did EMDR, which helped specifically with some of the physical and self-worth issues associated with my experiences of childhood neglect. I did participate in ASCA for a year. I had therapists coordinate with a member of my family, and I have had to learn to be more aware of my own dissociative patterns and how to manage that. And in my work, I've worked with 3 therapists. So I just didn't do one thing. So if I brought up something today and you're like, I don't do that. Oh goodness, I don't do that. That's okay. What do you do? You know, what are you interested in? What are you bringing to the table? And knowing that this isn't only you. We are members of a team here. There are multiple people, hopefully, working with this person, even if it's people on the sidelines or relationships. So that's important to note. So I want to leave enough time for questions.
So thank you so much, Amanda. Really, wow, that is so much important information in 50 minutes. I really applaud your ability to manage to fit all that in it's such a fantastic way. So we're going to go ahead now and leave these last 10 minutes for some Q&A. Also, someone in the chat just wrote great information. So Christina, do you want to go ahead and read the questions from the chat?
Sure. Thank you so much, Amanda, for that presentation. The first question we have is, can EMDR and IFS be used with children?
Yes. It looks a little bit different depending on the age of the child. They can be used. With EMDR, what I will do is I will combine it with another method like play therapy or drawing. So basically with EMDR, we want the child to connect emotionally to something and we want to desensitize. So here's an example of something I've done. I will have a children act out a scenario of abuse or neglect, and I will have the bilateral buzzies. They vibrate back and forth in their shoes or in their pockets so they don't have to worry about them. And I'll just kind of turn them off and on, observe. I might kind of check in. So yes, absolutely. And a lot of times I will combine the internal family systems with the EMDR work with the child and with adults as well. So we do sometimes have to deviate from our protocols. I said it out loud, I'm sorry, but our clients are very different. So we do have to combine methods. And so absolutely, you can do that EMDR and that IFS with children. You just have to be a little creative.
Thank you. So the next question is, what would be important for multidisciplinary team members to know about neglect, particularly when authorities are investigating neglect?
Right. So I would say be aware of, triggering, what's going to trigger your client, what do they need? They may need a lot of coping right away. With authorities, what I'm seeing more and more of is authorities working with clinicians and being more aware of this process. I'm seeing a lot of, we ask the child once and we don't ask again, which is good, or we videotape things, right? So we don't have to ask the child 20 times the same questions. So that's wonderful. So I would say when I'm coordinating with folks, I want to know, okay, when is the child going to be interviewed? What is the plan? Where's the child going after the interview? What does the rest of their day look like? What does their week look like? What are their support systems? Can they come in and see me, sometime soon after the interview? Kind of getting everybody on the same page. And sometimes children do very well with interviews. I don't want it to seem like it's always this traumatic experience. Some children, the interviews in a legal setting are very therapeutic. And that's wonderful. And we want to reinforce that. So I think getting everybody on the same page with one safety for one, not just physical, but also emotional safety. And as the therapist, depending upon how the client's doing, I might actually take a backseat from the trauma work for just a little bit to help the client to cope, refocus, reestablish that relationship with me.
Thank you so much. I think that's a great question. And Jimmy has contact with I think it's about 30, right, Jimmy? 30 multidisciplinary team across Oklahoma. So I'm sure that will be very useful. 37, thank you. that is very useful information for them. Also, I do want to add something, Amanda, which we haven't touched upon in this presentation yet, about really the effects and outcomes of childhood neglect. Because I have to admit, personally, I specialize more in the field of sexual abuse, so I was aware of the outcomes of, and the devastating consequences. But, neglect, I think what is often, the misconception often is kind of something, well, nobody really raised a hand at them, right? Nobody really touched them sometimes inappropriately. No one really, so it kind of seems like this not too bad kind of thing that might happen to a child, when actually what we do have is academic research that shows us sometimes the consequences are actually even worse than other types of child abuse, because we are such a relational creatures. We need that relationship in order to develop. And that neglect, even though no one raised a hand, right? No one touched inappropriately, no one did any of that kind of stuff, which we know is bad. But really that piece of neglect, and especially the emotional side of it, which you emphasized, I'm so glad you did, is actually so destructive. And we do have longitudinal research showing that at very young ages, children who have been neglected actually are worse off than children who have been maltreated in other ways. So I really wanted to just put that across, because, the public's, there's lots of misconception with the general public, and also I think as professionals. For me as a professional, I don't think I got enough training, or I don't think I even got some on childhood neglect. That is one of the reasons why I think it's so important to hear you today. So thank you so much for that.
Oh, you're so welcome. And whenever I work with clients where they have the big three, physical abuse, sexual abuse, and childhood neglect, what I've noticed is that the physical abuse and sexual abuse usually get resolved in treatment first. They're kind of the easiest to address, not easy, but easier to address and resolve. And it's the childhood neglect that sometimes takes folks years to treat and to heal.
Yes. Thank you everyone for commenting in the chat. And Amanda, I don't know if you can see the comments, but everyone was saying thank you so much. And that's such a great presentation. And so thank you for that. Any other questions before we finish, everybody? Jimmy's adding very informative and needed presentation. Thank you, Jimmy. So fantastic. You're getting another comment. So thank you everyone for joining us this morning. Really, we are very happy to provide this training for all of you. Thank you, Amanda, for joining us this morning from Chicago. Really, you did such a fantastic job. And I'm so happy that we have about 50 more professionals in Oklahoma who are now more aware about childhood neglect, assessment, treatment, and everything. So thank you so much.
Yeah, thank you for having me. I really appreciate it.
Have a great weekend, everybody. Bye-bye.
Bye.